it is noon on the dot, so we will go ahead and get started. I know you guys are all busy. My name is Kelly Compson. I am the manager of provider engagement for Mount Carmel Health Partners, and welcome to our very first virtual practice manager meeting. On the line from our team, you have our provider engagement team, you have our liaison team with the Mount Carmel Health System, and then quality and just a bunch of others from our team. So we're thankful you're here. Desiree, do you want to move this slide? We'll just go over the agenda real quick. So we're going to have some health system updates, which is always good. You know, things are always changing and moving and all sorts of new information. And then we will also do an Oscar Health agenda, some good important information for you guys to know for Oscar Health. So I will turn it over to, I believe it's Kathleen that's presenting.
Yeah, thanks, Kelly. Hi, everyone. My name's Kathleen Sheldon, and I'm the physician liaison with Mount Carmel Health System. And so today we just wanted to share a few system updates that have been going on. The first on the agenda is our neurosurgery service line and coverage. We previously were contracted with a neurosurgery group, and that contract ended in the beginning of this year, of January of 22. Since then, we have now hired 3 employed neurosurgeons to meet our system needs and our network needs, cover call at our hospitals, and see patients in their outpatient clinic. And we do have several other independent neurosurgeons who are supporting our system requirements and helping to cover call and all of that. And so joining us here today is Dr. Radwan. I think he's on the line. He is the medical director for neurosurgery, and so we just wanted to invite him here to give an update on the program and kind of where things are going here. So Dr. Radwan, are you on the line? Okay, he just texted me that he needs the link, so we can move forward. Hey, Kelly, could you send Dr. Radwan, resend him the Teams link? It sounds like he's trying to join.
Yep.
And when he hops on, we can bump back to him. But the next item that I wanted to review were some of our imaging updates. We have struggled, as have many other systems across the Central Ohio region and really the state and the country, to staff our outpatient imaging centers with techs and support staff. So we've made some really great progress in that, but it has been a challenge. Some of our imaging centers have had to close because of staffing issues, but we just wanted to note that we do continue to prioritize any of those higher acuity outpatient imaging studies. So every day we are holding spots for prostate MRIs, breast MRIs, anything that could really impact a patient's plan of care, treatment protocol, or long-term outcomes. We're always holding spaces for those. And I did have a chance to speak with our imaging director last night, and he informed me that some of the outpatient centers that have been closed are planning to reopen later this month. So you should see better availability for those outpatient imaging studies. But as always, those higher acuity referrals and orders are being prioritized. And go to the next. This kind of ties in with our imaging update. We did just roll out our online mammography scheduling. So patients are now able to self-schedule online for their screening mammographies. I went on and just kind of did a test run of it earlier this week. It's super easy. It shows all of the locations, and there is availability within like 24 to 48 hours at pretty much every location that we have. So we've kind of started with like a little bit of a soft launch there, but we will have some marketing materials that we can leave in waiting rooms and lobbies so that patients can take that information with them and go ahead and schedule their own screening mammographies. So that should be a big kind of patient satisfaction driver. And then we can go to the next slide, please. The last update that I had was just on some of the service lines that there have been changes in. Mount Carmel previously employed a few rheumatologists and urogynecologists. Those service lines, as far as employed physicians, those have been eliminated. So we do not employ our own rheumatologists or urogynecologists within Mount Carmel anymore, but we do still have specialists within Mount Carmel Health Partners that can care for your patients and meet those needs. So just a note on that, as far as rheumatology, urogynecology, Central Ohio Urology Group has some providers who specialize in urogynecology. And then for rheumatology, Columbus Arthritis Center has recently added several new providers, and we do have a few other options for rheumatology within the clinically integrated network to care for your patients. So those were the system updates. I'm not sure if Dr. Radwan has been able to connect yet. He just texted and said he's...
Oh.
Sorry?
I don't have his email to forward him the link.
Okay. I will do that right. I'll
Turn
go
it over
ahead
to
and forward it to him, and when he joins, I can send it to him.
I just went ahead and requested him to join through the chat.
Okay.
Excellent.
Thank you.
So we'll be waiting on him. While we're doing that, we can transition to the Oscar Health updates. We welcome their team and excited to share some new information with you. So I will turn it over to them and we'll advance the slides.
Okay, perfect. Can you guys hear me okay?
Yeah, and I just want to make sure everybody can see the slides. I know Jennifer couldn't see the slides. Can everybody else see the slides? I can see them.
I'm seeing them.
Okay.
I am too. I just sent her a chat. We'll send the recorded presentation out along with the slides after the meeting.
Okay, awesome. Well, hi everyone, nice to meet you. My name is Mia. I represent the Oscar Health Ohio team. I've been at Oscar about 4.5 years, and my team oversees all of our Ohio book of business. So work very closely with Kelly Rogers and the Mount Carmel team. We're excited to be here today. So want to tell you a little bit about Oscar. We've been in the Columbus market for a few years now and really saw substantial growth in the past open enrollment. So have definite confidence that you've been seeing some of our members, and we're grateful for your partnership. So we consider ourselves to be the first health insurance company built around a full stack tech platform, meaning all of our claims processing all done in-house. So have the ability to really customize claims payment and be able to sort of translate the tech into a provider workflow that's differentiated. We pride ourselves on really strong provider partnerships around historically narrow networks. So Mount Carmel has always been our core partner in the Columbus market. In a few slides, I'll sort of tell you how that network has split into both a narrow and a broader network and sort of what our trajectory in this market has looked like. And definitely the focus for us is member first. So our members have their own concierge team. What that means is at any given time, they speak to one of the same 7 people when they call in. And those teams are also geographically focused. So I'm based in New York City. If I call in, I'm speaking to only a care team that's familiar with a New York patient experience. Obviously super different from what a patient would experience in the Columbus market. So really making sure that member first approach is what that experience looks like for them. Next slide, please. So just to sort of show you how we've developed over time. So in 2014, we first launched an ACA product, so both on and off the exchange in the state of New York. In that first year, had about 15,000 members. Sort of fast forward to 2022, where we have over 1 million members and are in 22 states. We had our IPO in 2021, so that's sort of the most recent big milestone for us, is being listed on the New York Stock Exchange. And then the Columbus partnership and the Cleveland partnership, will sort of tell you guys about that in a second, what our trajectory has looked like in the state of Ohio. Next slide, please. So again, just showing you the states where we're in, the various markets. So like I mentioned, we have a little over 1 million members right now. And the biggest book of business for us is that ACA on-X, off-X program. We offer small group in some states. Ohio is not one of those. We offer Medicare Advantage in a few states, again, not in Ohio. So really the ACA is our original and definitely biggest book of business. Next slide, please. All right, so now sort of getting into the nitty gritty, showing you what this looks like in the Columbus market specifically. Next slide. So in Ohio, we first entered the Cleveland market in 2018, and we have a joint venture with the Cleveland Clinic. We're the only payer that offers Cleveland Clinic access through the ACA, and so that was definitely our original piece of entry in the Ohio market. The following year, 2019, we entered the Columbus market. Like I mentioned, Mount Carmel has been our core partner that whole time. So we've had, for the most part, Franklin, Delaware, Licking, and Fairfield counties. And then in 2020 added Madison, Perry, and Union. So that's sort of geographically what our presence looks like. So if a member wants to buy Oscar insurance, they have to have an address in one of the counties listed on this slide. Next slide, please. So in 2022, we really provided a differentiated offering. We actually offer 2 different network options for Columbus members. So the first is a narrow network, and that is just built around Mount Carmel and then Fairfield. And so that map on the left shows the big Mount Carmel facilities, Fairfield Hospital, and then the density is shown in the darker colors. So sort of the core counties where most of our members live, sort of expanding out into the suburbs. So that narrow network only gives those member access to a provider or facility within Mount Carmel or Fairfield. Definitely, I would say the vast majority of membership is in that network. So I'm sure that's going to be what you're most familiar with. One other alternate option now is this broader network. And so that again has that core presence of Mount Carmel and Fairfield, but also adds access to Nationwide Children's. And then again, in some cases, members do go up to Cleveland. So we have access to the Cleveland Clinic. That's definitely sort of few and far between given the travel time, but those members do have access to them as well. Next slide, please. So showing you what that looks like now translated to membership. So in 2022, we have a little over 13,000 members enrolled. Definitely a big membership jump because 2022, we're now the lowest price plan on and off the exchange. And definitely given sort of the characteristics of this membership, often that price is a big factor. So definitely saw a pretty significant membership growth. So that 13,000 members, these are sort of the density split based on county. So you can see from 2021 to 2022, largely the same counties have been our presence in the Columbus area, just sort of increased twofold based on what we had last year. Next slide, please. So definitely want to call out that membership density does generally trend with the locations of the Mount Carmel facilities. So that is good news. One thing to call out is our members do not have out-of-network benefits. So we are an EPO in the state of Ohio. So that means our members don't need referrals, but they also don't have out-of-network benefits, of course, with the exception being a situation of emergency. So for the large part, we are really encouraging routing within the Mount Carmel system. That density does generally align with where our members live and what the Mount Carmel facilities look like. So that's definitely good news. Next slide, please. All right, so to tell you about the Ohio State retirees, I'm going to pass this off to my colleague, Davisha.
Hi everyone, I'm Tavisha and I work with Mia at Oscar. I'll be taking us through the next few slides. So for OPERS, at the beginning of the year, OPERS members, who are the Ohio State retiree population, were given a health reimbursement arrangement, an HRA, which can be used to purchase any type of health insurance plan if they're too young to qualify for Medicare at this time. Previously, OPERS had their own pre-Medicare large group program, which they have now discontinued, so they're now able to purchase plans through the ACA. So we have this new pool of insurable lives. And oh, sorry, next slide, please. Thank you. 954 members from this new pool of insurable lives have enrolled in Oscar's plans in the Columbus market this year. As you can see, the bronze plan was the most popular, with 74% of these members enrolling in bronze plans. We also know that the average age of these members is 58, which is about 2 years older than the national average age in all of Columbus, which is 56. And next slide, please. Over here, we created a heat map of the membership density for these OPERS members. While the majority of this membership is concentrated in Franklin County, with about 10% in one zip code alone, the rest of the membership is actually spread out quite thinly across 85 zip codes. Next slide, please. We'll also be reviewing the member ID cards for the Columbus networks. Next slide. Over here, we have snapshots of the ID cards for members from both the Select network, which you can see on the left, and the Choice network, which is on the right. And as a reminder, Mia mentioned this earlier, the Select network consists of Mount Carmel and Fairfield, and Choice is Mount Carmel, Fairfield, and additionally Nationwide and CCF. Both cards are identical except for the text outlined in the red boxes, which calls out whether the member is part of the Choice network or the Select network. In addition to the network information, you can also find information on the attributed PCP, the membership ID, deductible and cost sharing information, as well as some helpful contact information for Optum and CVS, our behavioral health and RX vendors, respectively. Next slide. And I'll also be taking us through the new PT/OT authorization submission process. Next slide, please. Oscar is continuously looking for ways to improve the member and provider experience, and we have identified PT and OT auths as such an opportunity. So we've partnered with the American Specialty Group, ASH, to enhance and remediate provider eligibility determination. ASH has access to all of the in-network PT/OT providers within Oscar, and this will allow ASH to review PT/OT authorizations beginning September 21st as the go-live date. But already from Mount Carmel providers, this process has already started. So these slides will walk us through the submission process. So the auth request can be submitted via fax or the online portal ASH link. And if there are any questions or issues with this process, the ASH escalation information can be found here. And next slide, please. Thank you. This slide identifies the process of if an auth has already been submitted to Oscar, please continue to follow up with Oscar on these auths for any questions or concerns. But if an auth has been submitted to ASH, please contact ASH for any escalations moving forward. Next slide, please. And sorry, one more slide, please. And we were unable to get a resource to walk through the provider portal training. Sorry, one more slide as well. Thank you. So we have a few slides over here, I think maybe like 4 or 5 slides that walk through the provider portal training, but we were unable to get a resource to walk it through this meeting, but we've included these slides in the appendix of this deck as a resource. So please reach out if you have any questions or need help signing up for a portal login. Thank you, and that's all we have from our side.
Thank you, guys. We appreciate the update. I think it's always very helpful for our, practice managers to hear directly from the payers. So future meetings, if there is any particular payers or any topics you would like to hear about, we are welcome to suggestions. And I will turn it back over to Kathleen to introduce Dr. Radwan.
Yes, I'm sorry about the technical challenges earlier, but I do believe Dr. Radwan's on the line now. He is the medical director for our new neurosurgery team. So he's just here to introduce himself and kind of give some updates on the program and where we're heading.
Hi, can you hear me?
Yep.
Good morning. Hi. Can I share my screen? So is it under request control?
Yep.
There we go. Request control. Make sure I got that. Can you see my screen now, or? Let's see.
Actually, Doctor, it's the share box next to the leave button that you need to click.
Open share tray.
No, at the right top where it says leave and there's a red button. Next to it is a square with share on it. Do you see that?
It's on my Mac, so it behaves a little bit different, unfortunately.
Ah, okay. So, yeah. All right.
It does say share, open share tray, and now I have a share.
That.
Let's try that. Okay. All right. So it says desktop. Let me see here. Are you guys able to see this?
It's coming up. We got it.
Excellent. Yep. Fantastic. Well, good morning. My name is Tariq Radwan. I'm the new chief of neurosurgery. And what I'm here to do is to do a couple of things. First, I'm going to, go through about 5 slides of ways of introduction, and another 5 slides concentrating on a little bit of one of our, flagship new programs that we're trying to put together, hopefully to help all of our colleagues throughout the organization kind of get an idea of what we're trying to kind of build. So I call this Neurosurgery 2.0 mostly to, first of all, to acknowledge that we've had some challenges within the neurosurgery program at Mount Carmel. We've had a big gap for a few months, and that may have created some difficulties for our primary care colleagues in trying to get patients the care they need. I also want to highlight that we are in the process of moving to a complete neurosciences service line model, which is fully integrated between our different programs. So we're going to try and have neurosurgery, neurology, pain management, all under one single umbrella, which is coordinated between our outpatient arm, which is our clinics in neurosurgery across the 3 different big sites. So Mount Carmel East, Mount Carmel, St. Anne's, and Grove City, as well as our neurology teams. And we also want to integrate our PCP teams into that outpatient arm in good communication, back and forth, ability to refer patients seamlessly, and we'll talk about some of the models we're looking at. Under the leadership of Pat Hinton, who I know is on this call, who has had a rich and incredible experience in running some really successful neurosciences programs in Virginia on the East Coast. So that's kind of our 40,000 foot view from cruising altitude, and it will include the comprehensive spine program, which I will spend another extra 5 minutes just talking about in more detail. So our Neurosurgery 2.0, currently we have 3 full-time employed Mount Carmel dedicated neurosurgeons, myself, Dr. Mansour, my partner, who comes to us with a just similar to me. He's a similar kind of middle-aged guy like me with mid training experience, having about 20 years under his belt. So both of us are reasonably seasoned. We've run programs as 2-man and single-handed programs by ourselves and been very involved in program building. And then we have our young Turk, Dr. Hatef, who's a very, very smart new grad from OSU, very hungry to to help, and very, I know he's already reached out to multiple other teams, to try and, get the referrals and take care of the patients. And he's an amazing energy to bring into this program. And then we also have our clinic APPs who help both in the office and in the operating room, Shannon and Lily. And we have 2 new hires on board and due to hire another 5th very soon. As far as neurosurgeons, we're looking at the moment, we've been in the process of hiring another 1 and potentially 2 over the next 6 to 12 months. But we're kind of pacing ourselves. We're trying to sort out our logistical challenges and trying to get patients in and trying to get the system well oiled first. And then we're hopefully expanding to at least about 5 by next year or within 18 months. Just a few words about myself. So these are kind of the roles and the hats that I wear, both in terms of the neurosciences piece down at the bottom there, with the help of the Neurosciences Advisory Council, with the help of Dr. Garcia. She's the chair, and I'm the co-chair. We try and coordinate how we're going to provide our care across the 3 major sites at Mount Carmel, and together also trying to figure out the program building on a variety of different programs, not just in neurosurgery, but also in neurology. So, shout out to a couple of other programs, such as the MS program, and trying to get also things like interventional procedures done and pre-authorized in a timely fashion with pain management. Quick background about myself: there's a bio that got sent out, so that probably just bore you to tears. But very quickly, I trained in the United Kingdom and I grew up there, and I went to medical school at Cambridge. And then my UK training was a very prolonged process because of how the system is set up there, in that I actually did multiple specialties, including general surgery for almost 4 years, orthopedics, critical care, neurosurgery. So I have a very kind of a broad background. After 9 years of neurosurgery, I came to the United States initially thinking I was going to be a stereotactic and functional guy to do fellowship for a year and go back home, and I never left. So I ended up staying at Dartmouth and finishing a full residency program, another 6 years. And at that point, obviously I was still young, so my passion kind of changed from stereotactic and functional neurosurgery into complex spine, where I ended up in the University of Washington in Seattle. I basically completed a very, very heavy duty, busy, combined orthopedics and neurosurgery spine program. We did a lot of minimally invasive, we did a lot of tumors, a lot of complex deformity, revisional cases. It's also the single busiest level 1 trauma center in the United States. Even despite there's other bigger cities than Seattle around the country, they all have multiple level 1s. Seattle really covered about 5 different states geographically, and they had five airlift Northwest, 4 helicopters and 3 fixed-wing planes. So it was a very busy place. So I had a lot of fun there, and came back to the East Coast. Initially, I've been basically working as an attending and building programs for about 11 years. So the focus areas we really concentrating on here at Mount Carmel is very robust program building of neurosurgery predominantly, trying to incorporate all the comprehensive aspects of neurosurgery, and the guys we have here are able to offer the full gamut. We obviously are a level 2 trauma center. We are looking at potentially expanding our services and even stepping up to level 1 with the help of Dr. Dizon from the leadership team from the trauma program. The research part is the one thing that's still kind of hampering us, and hopefully we can move that forward. The Oncology Service, we've already participated in multiple tumor boards. We've had a very successful, over the last 3 months, Dr. Mansour and I have had a very successful oncology expansion of services. We've had so many cancer patients, and I think it's the place is clearly busy with a lot of cancers around, particularly spinal cancer, but also a lot of metastases and primary brain tumors. And then we're in the process of trying to improve the model of neurocritical care provision within the hospital systems, particularly at East, which is our flagship hospital. We're looking at hiring a neurocritical care physician to oversee our APPs. A quick word about our APPs. In the hospital, we have over 22 advanced practice providers. They're all nurse practitioners who are extremely experienced at taking care of the patients. They do a lot of our initial consults and triage, and those are a gold mine for helping us take care of these patients very well, especially when the place is really, really busy. And then we have multiple clinical care improvement initiatives, looking at protocols, guidelines, stepping into the world of participation with benchmarking with outcomes with other databases that are national now. So the neurosurgery N2QOD program, which is run by the American Association of Neurological Surgeons, has a very large database that we're hoping to get our outcomes program started and then plug in our data in there and do benchmarking. And then finally, we're looking at the education and professional development of all of our teams, both our APP teams in the hospital, our APP teams in the office, and outreach to our partners in primary care to hopefully have a two-way communication about what are your needs, both from a professional development standpoint as well as patient care. And then now that's kind of like the quick 40,000-foot view before I switch gears and talk about the comprehensive spine program. So I'll just give maybe 60 seconds if anyone has any questions on what I just said. So anyone, any questions? Okay, so I will just quickly switch gears here, and I have 5 very quick overview slides. This is a very long talk, but I won't go through it. I will skip straight to a couple of things that that we are looking at. We are looking at building a comprehensive spine program here at Mount Carmel. The first thing to say is that there are certain elements that we're really very much invested in trying to bring to our primary care colleagues and partners, and that is first to focus on access, defining entry points, timely evaluations, dedicated care coordination. We are bringing on a nurse navigator who will be responsible for immediately getting any of the new referrals and triaging appropriately either to neurosurgery, to pain management, to neurology in certain cases, or even getting supplementary investigations such as MRIs, getting pre-authorizations done, or having a communication with the primary care and facilitating any conservative treatment that needs to happen in advance of that process. This will be a multidisciplinary offering, and we're hoping that it's going to be a two-way communication process. We're hoping to look at improvements in the referral process and having our work queues a little bit more streamlined. Currently, we have, I think my understanding, we have at least 3-4 different work queues, and unfortunately, with implementing Epic, it hasn't been standardized and optimized in the best way we want. And over the next couple of weeks, we're doing a soft launch of a new referral process where there will be one single order you're able to put into Epic, and it will immediately fire to our spine nurse navigator, who can take that referral immediately and put it into the right bucket. I apologize if there's some delays have been in the last few months before we got here as a team. That my understanding that some work queue leftover things that are still sitting in our work queue, and we're hoping to clear that off, clear that backlog over the next month or so. Just quickly move to my next. Get the right. So 16. So this is just to acknowledge where these spine patients go for care. You could see primary care, family medicine is sort of the number 2, but a lot of patients take the referral process in their own hands, and they go and see chiropractors, osteopaths, all kinds of other care providers. And so we certainly depend very much on our primary care colleagues for where these patients come from. And hopefully by having a very integrated, well-coordinated care management process, we can take care of both the patients and the family practice providers' needs. And again,
Dr. Rabbit,
yes.
Slide portion, or if you're just talking through it, I just want to make sure that we weren't missing anything.
Sorry, say that again.
I said, so I'm not sure if you have slides for this portion of the presentation. You might just be talking through it, but I just wanted to make sure if you did have slides that we could see them.
Are they not projecting?
Mm-mm.
Oh, okay. Hang on, let me see here. What did I do wrong? Let's try again.
I'm telling you, it's been difficult.
I apologize. It's my crazy Mac. I think that's the problem. Let me try this again. Okay, so go back there and share tray. Make sure. Is this coming up? Can you guys see it?
Yep,
Okay, so
you're good, thank you.
Yep.
all right, excellent. Apologize. My Mac does behave in a weird way with Teams. So this is what we were talking about in comprehensive spine program elements that I just mentioned. I'll skip quickly to this, where we mentioned that patients come in to a variety of care providers. Sometimes they pick and choose. Sometimes it's an insurance company dictates where they go, but oftentimes our family practice colleagues are the very first port of call, quite appropriately, because of course, as neurosurgery and neuroscience teams, we see a very, very tiny percentage of what you guys see out there in the in the primary care world. You see all the patients in a very, very large bucket. And like I said, I always tell patients, 90% of America's got back pain. But if every single one of those saw neurosurgeons in the office, number one, neurosurgeon won't have anything else to do. And number two, they'll all probably get treated inappropriately because a lot of them are getting inappropriate operations. So just an acknowledgement of the huge amount of work that our primary care colleagues here do. And again, of course, the patients will sometimes pick and choose where they go. There's a variety of different access channels into optimum spine care, some of them in acute care, some of them coming through the community, and some of them even coming through diagnostic imaging centers. 18, 19. So I think the kind of the key thing, the key message really is care optimization. How do we optimize the care of these patients? And like I just mentioned, the bedrock of most spine care is essentially elective referrals, and these are conservative management is the #1 treatment. Nobody should have surgery who doesn't need surgery or could get better without surgery. And this is coming from a surgeon saying that. And that's because you only get the best outcomes if you pick the right patients, they're appropriate for potential surgical candidates, and you can clinically justify why they need surgery. And oftentimes now our world is ruled by insurance companies who require us to have X, Y, and Z done ahead of time in order to even get pre-authorization for surgery, for MRIs or advanced imaging, let alone surgery. And of course, the other piece is that we need to have a channel to fast-track patients who need an urgent or an emergent care in a timely fashion, and that's what we're working on with our Spine Navigator, in that if you call a single number and speak to a single person or put a single order on Epic, we should be able to fire up immediately. If that patient is an urgent patient, needs to be seen, we're happy to try and get them in within 24 hours, versus a patient that can be seen within that week or the week after. And so that's the kind of the care optimization we're looking for. And then the most best way to describe this is that we need to funnel the patients in steps that are logical, necessary, and clinically effective, evidence-based. They progress in escalation of invasiveness. So you don't have surgery first and then you go and get your epidural. First of all, you get to see your physical therapist. Then you have your pain management physician optimizing your medication. Then you get your epidural. Then if necessary, then you see the surgeon, and then you get surgery. And then the last piece is looking at cost effectiveness and how we risk mitigate any procedures these patients get. And that comes into a two-way process with, if a patient needs surgery, we often will have them go back to their primary care provider and request a kind of a partnership in evaluation of what is their risk for surgery in this patient. So, the patients we often see, a lot of patients in our community who, they're on 5 liters of oxygen at home, they weigh 300 pounds, and their A1C is 12. Well, those are not very good surgical candidates. And even though, they may need surgery at some point, there's a little bit of homework between both the specialist and our primary care colleagues that kind of needs to happen before we can take care of those patients in an appropriate way. So that's kind of my headline figures. I know that often times clinicians are kind of get bored to tears by some of this process talk. So what I'll do is I'll just give you 3 or 4 clinical cases just to refresh things and make it a little bit more interesting. Just very quickly, talk about some illustrative cases. So some simple, very simple, straightforward stuff. Here is an example of a young, healthy, athletic female who's a fanatical jogger. She's got a nice, big, juicy disc herniation. She's had more than 10 weeks of leg pain and back pain, has tried non-operative treatment with oral steroids, injections, no effect. She has a back pain to leg pain ratio of 20 to 80%. So she's leg pain dominant. She's got a positive straight leg raise and a crossed straight leg raise. And she was actually in tears testing her straight leg raise. So this is a great surgical candidate who's going to do very, very well from minimally invasive lumbar discectomy. And this is kind of what we did in the operating room. We put an incision on her back that's 22 millimeters in length. Put down a tube. We operate through the tube under the microscope. That's the lamina on the left. Right here, I don't know if my pointer works. That's her ligamentum flavum. We do a fenestration and we move the nerve root out of the way. There's the fecal sac nerve root here, and in the axilla of the nerve root, you can see that nice juicy little disc. This came out, and that's her incision, 22 millimeters. Patient has no leg pain. She has a follow-up, and this is really important. We have follow-up at 2 weeks, 6 weeks, 3 months, and 12 months. And I actually have some 3-4 year returns in some of my more complex patients. Her incision is healed now down to 19 millimeters. She's doing very well, and she was actually back to work. So this is kind of the MIS kind of side of things. More moderate level spine surgery is a classic example. Here is a working guy who owns his own bread company, and heavy lifting, a lot of heavy duty physical manual work. Has been having pain for almost 8 years, severe, unable to work. He's failed multiple non-operative treatments. He's gone through the ringer with pain management. And this patient characteristically has a very substantial amount of disc collapse and a lot of high signal within the MRI and in the bone marrow. And he makes a really good candidate for a standalone anterior lumbar intrabody fusion going through the abdomen with a very small incision, helped by one of my colleagues from vascular surgery who helped do the approach. So it's a very limited incision. We're down to the front of the abdomen here. That's the iliac vein being retracted on the right of the image. The disc is out, and an implant is placed. And this is his post-operative imaging with weight-bearing standing. You can see he's restored his beautiful lordosis. He has a lot of height expansion in his disc space. And he has a follow-up at 1 year with 0 back pain score and a VAS score and a 0 leg pain score, excellent lordosis, and on his CT, you can see he's got a solid arthrodesis. So that's the kind of intermediate level. I'm just going to move quickly to one single final case, just as an example of some of the more extensive stuff. And again, you can see that on these slides, I've talked a lot about pre-operative medical optimization on some of these patients that require, often they can take a long time. They can take 3, 6 months, 9 months to get right before surgery, particularly our more elderly patients and the patients who have diabetes and other medical conditions that will need a little bit of optimization. Just quickly, so this is a gentleman here that had a prior fusion. He's actually had 2 fusions. He's had an L5S1 and a posterior L4-5 fusion in tandem, about 6-7 years apart. This is 15 years after the event, and he came in with essentially intractable inability to stand for almost more than 5 minutes to even cook a meal in the morning. And you could see his head is way in front of his sacrum. We call this the sagittal vertical axis, where patients have a very severe sagittal deformity. This has not been recognized even in the spine world up until 10 years ago. Everybody knew what a scoliosis looks like on the right here. It's a very mild scoliosis. But this gentleman's problem was not the scoliosis. His problem was that his head was way in front of his hip and his ankle. And so this is kind of a mention of what we call the cone of economy, that patients have symptoms when they fall outside that cone of economy, when their body's tilted back or forwards. Sagittal deformity is one of my big passions, because I see a lot of patients who've had prior fusions, and unfortunately, the way the fusions used to be done in the past, and even up to now, sad to say, involves giving patients a lot of flat back deformities, where they're basically fused on the table in the same position they already started with. And the principle of the thing is to basically restore their lordosis, to give them back some of that curve that balances out with the pelvic incidence. And this is the kind of data that we've only really been studying in the United States in the last probably 10 years. The French scoliosis surgeons have been writing about it since the 1970s. and that is restoring this perfect harmonious sagittal balance where the head and the cervical spine is right over the sacrum, right over the hip and the heel. And this patient underwent a multi-stage complex procedure where we had to take all the instrumentation out posteriorly, put in screws, do a temporary closure. He had to be flipped over and put in these anterior interbody cages to gain more lordosis anteriorly and give him more curve, and then went back for a second part 2 to put in the instrumentation. You can see the difference that he's got a huge amount of lordosis now at 54 degrees, prior at 7, and now his pelvis and his lordosis and his lumbar spine are balanced. Now that all sounds probably like gibberish to a lot of my primary care colleagues, but here's what this looks like in real life. So this is his prior and the way he was standing, and you can just look at this and say, this guy looks like he's in pain. He can't stand for more than 10 minutes. And after we've given him lordosis, his head is right over his shoulder, over his hip, and over his heel. And one of the beautiful things about this is that we now are able to monitor these patients over a period of time and watch what their Oswestry disability scores, was visual analog scores, and their SF36. Here I'm missing some data here because it's being calculated by my my MA, since SF36.org became proprietary. So we have to get assistance from our data team to get some of our quality data up to snuff. But you can see his back pain, leg pain scores are 0. His Oswestry disability is basically at 10, pretty minimal. And the guy at 72 years old, he actually returned to working. So that's kind of just a quick flavor of some of the cases we've done over the over myself over the years, just kind of giving you a flavor of both the sort of the good, the bad, and the ugly of the variety of things we've been able to do. And hopefully that kind of sparked a conversation both about access and what kind of things you feel we can help your team with. So I'm open to questions. Thank you very much for the opportunity.
Dr. Radwan, thank you so much for sharing that data. It was very interesting. What is the best way for our practices to send a referral to you? Is there a form? Do they call? What does that process look like?
So at this moment in time, if we could still do the referral via Epic to Mount Carmel Neurosurgery, and Pat, our director, as well as Shannon, our practice manager, is in the process of setting up a single magic word on Epic, where we'd be able to refer. If it's a cranial case, you could still refer to neurosurgery as usual, so Mount Carmel Neurosurgery. And for the spine patients, we're trying to get this more streamlined, so it'll be a single spine referral. There will also be a single telephone number published for your staff and your front office. If you feel that Epic is not doing the job for you, you can just call that single number and be one person who's an intake specialist who will handle that referral from A to Z. And then ultimately, I will also have my cell phone sent out to all of our colleagues here. If you have a patient that you want to take care of in an emergent or something is really bothering you, just call me directly and I'll be able to triage that.
Great, thank you so much. I know a lot of our independent providers are not on Epic yet, so we'll share that phone number with them to make sure that they're brought into the loop. But it's great information. I enjoyed it. I learned something.
And Kelly, excuse me. There is a referral form, and it's being updated to include Dr. Hadiff's information since he just joined last month. And so as that is updated, I will get that sent out to you so you can share with all of the practices. Awesome.
Thanks, Kathleen. Appreciate it.
Mm-hmm.
And Kathleen, can providers make that referral through Epic CareLink?
That's a great question that I am not sure about what that looks like. So I'll have to get back to you on that. I know we've had some issues with the referral process in Epic CareLink, so I don't know exactly where that stands today.
That's something that we're trying to iron out, hopefully in the next couple of weeks. Like I said, because we've just gotten our RN navigator situated this week.
Great.
And we'll share that information with everybody. We'll send out the slide deck and the recording as well to all of you in case you have other colleagues who want to listen to the presentation or have questions. So Any questions for any of our presenters at all? Well, you can always reach out to me after the fact if something comes up. Then my name is Kelly Thompson, and I'm the manager of provider engagement. So if I don't know the answer, I can get you to the right person that will. So we just appreciate your time, appreciate our presenters, and we will finish 10 minutes early.
Thank you.